Welcome back to the third day of the IYAC Congress. This section will be about the clinical updates in congenital heart diseases. I will moderate this section with my dear colleague, Dr. Abdallah Almaghraby. The first speaker is Dr. Giovanni Di Salvo from Italy. His speech will be about the state of the art in congenital heart diseases.
Ladies and gentlemen, thank you very much for this invitation. It's my great pleasure to be here at the International Young Academy of Cardiology e-Congress, and I'm very happy to discuss with you what is the state of the art in congenital heart disease for the echocardiography. Before starting, we need to remember from where we started, and this is the very starting point. Hedler and Hertz working together to apply for the first time ultrasounds to cardiology. And this is the first recordings and a mode of the mitral valve. At that time, there was a greatest interest for the mitral valve because of the rheumatic heart disease. And you can see this very historical mode tracing of the mitral valve. But nowadays, we can see the mitral valve on 3D. We can see all the commissure, we can see the scallops, we can see the neighbor structure, we can see the mitral valve from the atrial level, from the ventricular level, and so on. And nowadays, 3D echocardiography is standard of practice, is inside the clinical arena, because we don't need geometrical modeling. We can have a more objective measurement of chamber size and function, and we can have a unique view of cardiac pathology, and this is particularly important in the preoperative assessment and to guide interventional procedures. Why? Because in one view, we can see all the information that we need without any reconstruction in our mind. This is particularly important for ASD. In just one view, we can see all rings, and we can guide the procedures and see the interaction between the catheters and the device and the defects, as well as with neighbor structures. But also sometimes in the assessment of VSD, 3D echocardiography can be very helpful, because sometimes we don't know if there are two defects or is it just one defect extending from one region to another region. As here you can see an extended perimembranous to outlet VSD with an inlet extension. We can beautifully see it on just one view obtained in 3D echocardiography. Or complex mitral valve regurgitation, as in this case, where you can see a mitral regurgitation, and then you can see from 3D that there is a very nice cleft in the posterior leaflet of the mitral valve. Or in univentricular heart, we can use 3D echo to better understand the pathophysiology of AV valve regurgitation. As in this case, the left AV valve is a trifoliate left AV valve, and is the cause of the AV valve regurgitation. Or in a patient who had Epstein disease corrected with cone repair, but with a residual periannular leakage. Well, we did percutaneous closure of this periannular leakage, and 3D echo was extremely helpful to guide the procedures, and this is the beautiful results where you can see the reconstructed valve according to the cone procedures and the device closing the perivalvular leakage, and you can see how the reconstructed tricuspid valve works very well. But not only echocardiography improved in these years, we had a huge improvement also in the Doppler technique. This is one of the first Doppler tracing, and nowadays we can use Doppler not only to assess flow, but also to assess tissue properties, tissue Doppler, or even to assess myocardial deformation. And nowadays we can assess myocardial deformation from 2D images, assessing the speckle tracking pattern. In this way, we can assess myocardial deformation without any angle dependency and without the Doppler limitation. And indeed, with this approach, speckle tracking technique, the assessment of myocardial deformation property is very easy and is implemented currently in the guidelines. This technique is extremely helpful because we can use it to understand complex situations like a differential diagnosis between left ventricular non-compaction and hypertrabeculation. Giovanni Sabatino demonstrated that studying the rotational of the apex and left ventricular twist, we can discriminate a true left ventricular non-compaction from an hypertrabeculation in pediatric patients. Another issue in congenital heart disease is the assessment of diastolic function. This is particularly difficult in children, and this nice study, the 6 children group from Toronto, demonstrated that all the parameters included in the guidelines, they do not work well in pediatric patients. They are not even able to discriminate healthy children from children with cardiomyopathies. Based on this study, we did a similar study, including all the standard parameters included in the guidelines, but also including atrial strain. We studied 45 healthy children as control group, 44 dilated cardiomyopathy children, 40 hypertrophic cardiomyopathy children, and 7 restrictive cardiomyopathy children. Once again, the standard parameters, including tissue Doppler and left atrial volume indexed, were not able to discriminate healthy children from pathological ones. On the other side, atrial strain decreased significantly from controls to dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy, and very clearly discriminate healthy children from children with cardiomyopathies, and was also very good in discriminate hypertrophic cardiomyopathy and dilated cardiomyopathy from restrictive cardiomyopathy. But we can use this technique also in complex congenital heart disease. The most important one is no doubt hypoplastic left heart syndrome. At Royal Brompton, we had the unique opportunity to do in-hospital monitoring of hypoplastic left heart children from Norwood stage 1 to Norwood stage 2. And we did serial echocardiographic assessment, including also speckle tracking technique. And Nunzia Borrelli nicely demonstrated that a drop in longitudinal strain around 10% was the best predictor of poor outcome in this patient. And this could serve to identify the subgroup of patients, hypoplastic left heart children with higher risk of poor outcome. But nowadays, we can use blood flow speckle tracking. So we can apply the speckle tracking technique not only to the myocardium, but also to the blood flow. In this way, we can get rid of the Doppler deformation, and we don't need anymore to have a good alignment, and we will not underestimate velocity because of angles. And this technique can be used in healthy children as well as in children with congenital heart disease. We can study the vortex formation, which is a way to preserve energy that nature uses. And we can see how the fluid dynamics is abnormal in simple VSD as well as in complex congenital heart disease, or we can use it without need of any contrast agent also to assess the fluid dynamics in the aortic arch. But where are we in 2020? Is there anything else? Well, in 2020, we are witnessing the advent of artificial intelligence and deep learning. This has improved a lot the workflow in the Echo Lab because from a parasternal view, the software automatically will stop the frame in end diastole and systole, and we do all the measurements. In this way, the quality of our work, the reproducibility of our work is great, and this improves a lot our measurement, especially in the follow-up, because there will be virtually no errors in terms of different measurements, so reproducibility will be 100%. This not only for simple measurements, but also for complex measurement like speckle tracking. Once we acquired 4-chamber, 3-chamber, and 2-chamber view, then the software automatically starts the segmentation and automatically provide us the results in terms of longitudinal strain, but not only peak velocity, also time to peak velocity, volumes, and ejection fraction. Once again, in a few seconds, we can have a lot of information with excellent reproducibility. And artificial intelligence is also a way to improve the image quality, as demonstrated in this nice study by Gerhard Diller, where the noise of an image can be corrected by using artificial intelligence, as well as stationary artifacts can be removed from the image. And we can use also augmented reality in 3D echo to see the dynamics between the mitral valve and the aortic valve. So, and I come to my conclusion, advanced echo in congenital heart disease is nowadays standard of practice. Artificial intelligence and deep learning is already reality, and probably we didn't realize it yet how powerful they can be. So, if we don't look ahead, the future will leave us behind. Thank you very much for our attention. Thank you.
Thank you so much, dear Professor Giovanni Di Salvo, for this great lecture. Our next speaker now is Professor Dr. Giulia Tuo from Italy, and she will speak about fetal echocardiography.
Good afternoon to everyone. Many thanks to the organizer of the Congress for the kind invitation to the e-Congress. I'm going to talk about fetal echocardiography. And first of all, I want to remember that the incidence of congenital heart disease is about 8 out of 1,000 live births, and that the major congenital heart disease has a prevalence of 2 out of 1,000 live births, and that the cardiac anomaly is still a leading cause of infant mortality. However, the structural cardiac anomalies are also among the abnormalities most frequently missed by prenatal ultrasonography. And this is the reason why during the years we try to optimize the screening, the cardiac screening examination for maximize the detection of heart anomalies during the second trimester obstetric ultrasound. When I talk about fetal cardiology, I used to think about a pyramid, and at the bottom of it, I put a screen for congenital heart disease. That is something different from fetal echocardiogram. The first one is performed by the obstetrician that has the aim to look at the heart and recognize that something is wrong. And in 2013, the International Society of Ultrasound in Obstetric and Gynecology published the new guidelines that were updated for improving the detection rate of congenital heart disease, because they include in the cardiac screening not only the four-chamber view but also the outflow tract view of the heart, going from a 50% of detection rate of cardiac anomaly during the second trimester of pregnancy up to the 90% of detection rate. So with the four-chamber view, the obstetrician can have a look to the heart inside the thorax, can have a look to the dimension of the heart and of the single chamber, so they can have a look to the two atria, the two ventricles, the septum, the interatrial septum, and the foramen ovale flap. And they can also have an idea of the function of the heart and also the rhythm. But adding also the left and right outflow tract of the heart, they can add important information that regards the ventricular arterial connection, the relationship between the two great vessels, and the dimension of the great vessel. And this can give the chance to diagnose also the conotruncal anomalies. So when the obstetrician have the suspicion of a cardiac anomaly, so there is something abnormal on the routine obstetric ultrasound, that fetus needs to have a fetal echocardiogram as soon as possible, because it needs of a precise diagnosis, especially when the lesion is at risk for fetal cardiovascular compromise. And it is important to do it as soon as possible, also because we have to give to the family the chance to have further information and further analysis, like the amniocentesis for the fetal karyotype. So when we talk about fetal echo, we have to talk about the indication, the aim of the exam, the person that have to perform the exam, and the components of the exam. All these answers are inside these guidelines published in 2013. So first of all, what is the fetal echo? Is defined as a detailed sonographic evaluation that is used to identify and characterize the fetal heart anomalies before delivery. So it is like an extension of the basic and then extending basic fetal cardiac screening performed by the obstetrician. It is commonly performed between the 18 and 22 weeks of gestation, but we can perform it also earlier in specific cases. And which are indications? There are maternal indications, like, for example, a metabolic disease or autoimmune antibodies. But there are also many fetal indications, like, for example, first degree relative of a fetus with congenital heart disease. But for sure, the most important indication for performing the fetal echo is the abnormal cardiac screening examination. And who is the person that has to perform the exam? It could be a pediatric cardiologist, it could be an obstetrician, it could be a maternal and fetal medicine specialist, it could be also the radiologist. But all of these specialists need to have received the good training for acquiring the pictures, and needs also to know in details the fetal circulation and also the transition to the fetal circulation to the postnatal one. And what about the components of the exam? As you can see, this is a very long list of components, from the structural information that we have to get from the single exam, going through the rhythm analysis, adding also other techniques that the obstetrician do not use, like the color Doppler and the pulse Doppler. So this is one of the further view that person that performed the fetal echo needs to acquire, and this is the long axis view of the left ventricle that allow us to assess the mitral aortic continuity posteriorly and the septal aortic continuity anteriorly. And the other important view is a three-vessel and three-vessel trachea view. That is this one that allow us to have information regarding the dimension of the vessels, the great vessels, and also the relation between the great vessel and the trachea. Moreover, as I said, we can put the color Doppler for studying the pulmonary vein, for better understanding of the shunt across the interatrial septum, for be sure that there is no ventricular septal defect, and also for studying the atrial AV valve and the semilunar valve. And for this indication, we can also use the pulse Doppler. The color Doppler and the M mode together are useful for the study of the rhythm, because we put in correlation a mechanical event that is the atrial contraction, another mechanical event is that ventricular contraction, and we know that these two events, mechanical events, are correlated to other two electrical events that are the P wave respectively and the QRS wave, and this is useful for the rhythm study. And the M mode is also useful for the study of the function of the heart. There are other techniques like the 3D and the 4D echo, or the strain and strain rate, but we do not use them in the clinical practice. Until now, at least, they are used only in specific cases and also for scientific aim. So going back to the pyramid, after having performed the echo and having made the diagnosis, we have to go for the counseling. That it is not less important, but it is even more complex than doing the diagnosis. At this time, we have to talk with the family, providing the explanation of the diagnosis, the clear picture of the prognosis, and eventually the possible management and the treatment options of that cardiac disease. After that, what happened? So today, because of the improved quality of the ultrasound equipment and also because of the improved accuracy in the diagnostic capacity, we can have an impact both on the fetal and on the postnatal outcome. Fetal because we can treat some condition like the fetal arrhythmia, both the bradycardia and the tachycardia, and we can treat some specific condition like the aortic stenosis, especially the aortic stenosis, in which we have the stenosis and we have the evolution from the stenosis to the hypoplastic left heart syndrome. So with the fetal valvuloplasty, we try to stop that involution of the heart, and in that way we try to improve the natural history of that condition. And also we can impact on the postnatal outcome because when we have diagnosed a major congenital heart defect, the cardiologist of the one that performed the fetal echo has to talk with the other specialists that are involved in the fetal medicine team for scheduling the delivery and plan the time of delivery for applying the best management for that fetus, because we have to anticipate the postnatal level of care for the single fetus that received the single diagnosis. So we have to decide where that fetus has to be delivered and the level of neonatal care he has to receive. In particular, there are few conditions like the HLHS, the hypoplastic left heart syndrome, or the transposition of the great artery associated with the restrictive interatrial septum that represent an emergency sometimes. So we all have to be ready for treat the baby, because we already know a lot of important information from the prenatal assessment. So I'm going to conclude that in the modern era, it is expected that structural diseases and arrhythmias will be diagnosed with precise detail in utero. But the goal today, the goal of the fetal cardiologist has become to understand the fetus as a patient, knowing that now it is possible to modify the natural history of CHD. And further study is needed to standardize treatment strategies to prevent cardiovascular compromise and disease progression. Many thanks.
Thank you so much, dear Professor Dr. Giulia Tuo, for your great lecture. Our next speaker now is Professor Dr. Fuad Samadov from Azerbaijan, and his talk is about imaging in arrhythmogenic cardiomyopathy. Please.
Hello, everyone. My name is Fuad Samadov. I am going to talk about echocardiography in arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy is characterized by progressive replacement of the myocardium by fibrous and fatty tissue. This process starts from the epicardium or mid-myocardium and then extends to become transmural in the right ventricle, which is leading to wall thinning and aneurysms typically located at the inferior apical and infundibulars walls. The LV involvement is present in more than half of the cases and is often confined to the posterolateral region. It is recommended to rename this entity as arrhythmogenic cardiomyopathy in recognition of the biventricular disease expression. Traditionally, subtricuspid region, RVOT, and the RV apex were considered as the classic triangle of the dysplasia, but recent studies have shown that RV apex is involved in a more advanced stage of the disease, and the LV is more commonly involved than previously thought. Arrhythmogenic cardiomyopathy is a genetic disease, and there is reduced penetrance and variable disease expressivity even within families carrying an identical mutation in a desmosomal gene. Even if the patient carries a disease-causing mutation, he or she might have definite possible or borderline arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy cannot be diagnosed by a single test. It's a clinical diagnosis supported by various criteria. Arrhythmogenic cardiomyopathy is probably within the field of cardiology the single most complex disease to diagnose. Diagnosis of other cardiomyopathies is more straightforward than arrhythmogenic cardiomyopathy, but for diagnosis of arrhythmogenic cardiomyopathy, we have several criteria. Here you see just imaging criteria from International Task Force Criteria 2010. Recently, the Padua criteria has been introduced with special emphasis on dominant left arrhythmogenic cardiomyopathy, and it is required to demonstrate with a cardiac MRI left ventricular late gadolinium enhancement plus arrhythmogenic cardiomyopathy gene mutation with no or minor RV criteria. Conventional echocardiography is part of the current diagnostic task force criteria. It consists of visual regional wall motion analysis, RVOT dimension measurement, and RV fractional area change calculation. Akinetic, dyskinetic, or aneurysmatic RV wall segments are considered abnormal. Importantly, hyperkinesis isn't part of a task force criteria, because regional hyperkinesia is a common finding in healthy individuals too. Optimal visual RV wall motion analysis is crucial, and all RV regions should be visualized during the examination. Here you see different segments of RV and RVOT, and if the patient is suspected to have arrhythmogenic cardiomyopathy, all the segments have to be examined. These echocardiography clips are from a 37 years old lady with frequent ventricular arrhythmias. In this first clip, you see aneurysmatic area in RVOT, and second one, aneurysmatic segment in RV anterior wall. Of course, it is important to find and demonstrate wall motion abnormalities in right ventricle, but it isn't enough for diagnosis. Also, it is required RVOT dilatation or RV fractional area change reduction. RV fractional area change is very important, and if FAC is equal or less than 33% and there is regional wall motion abnormality, this combination is a measure criterion even in the presence of normal RVOT size. In this slide, you see two different tables. Left one is from the most important publication in this area. It is published in 2005 and is a major evidence source for the task force criteria. here you see frequency of various echocardiographic parameters, and there are also hyperreflective moderator band and excessive trabeculations in right ventricle, but it isn't, they are not included in task force criteria because they lack sensitivity. In the right one, we see EACVI recommendation for echocardiographic evaluation of the patients with suspected arrhythmogenic cardiomyopathy, and there are also right ventricle basal diameters, also TAPSE longitudinal strain for RV free lateral wall mechanical dispersion, and so. These images are showing hypertrabeculation or excessive trabeculation and hyperreflective moderator band. Of course, these findings are not enough for diagnosis, but they support diagnosis of arrhythmogenic cardiomyopathy. Deformation imaging is very important too, because it reveals subtle wall motion abnormalities, often in the absence of RV dilatation, global RV systolic dysfunction, or visual wall motion abnormalities. Cutoff value of -18% peak systolic strain is a reliable parameter to differentiate between normal and abnormal RV segments. In asymptomatic arrhythmogenic cardiomyopathy, mutation carriers, systolic peak strain, and the presence of post-systolic shortening were abnormal in 71% of cases, even though imaging criteria were not met by the 2010 task force criteria. Here we can see a strain imaging of the right ventricular free wall, and the first curves are from the normal individual, the last one from the arrhythmogenic cardiomyopathy patient, and the middle one is from the cardiomyopathy patient relatives. In the last curves, we can see that apical segment strain is normal. In the middle segment, strain is reduced, but in basal segment, which is shown with red curves, there is systolic stretching and also reduced strain. Also, mechanical dispersion, RV mechanical dispersion is important too, and the cutoff value of 25 or 30 milliseconds is very important to early detect arrhythmogenic cardiomyopathy mutation carriers. And an important study showing that arrhythmogenic cardiomyopathy patients have reduced strain values in the rest and also after stress testing, and they showed blunted increase to stress testing in right ventricular strain values. And how we can differentiate arrhythmogenic cardiomyopathy versus athlete's heart? Of course, in athletes there is right ventricular dilatation too, but in athlete's heart, RV is dilated in RV main body, but in arrhythmogenic cardiomyopathy, there is a marked dilation of the RVOT, and RV-LV ratio is less than 0.9 in arrhythmogenic cardiomyopathy, but in athletes is greater than 0.9. And of course, right ventricular functions is normal or mildly depressed in athlete's heart. Echocardiographic parameters which can predict MACE in arrhythmogenic cardiomyopathy patients, they are TAPSE less than 17 millimeters, fraction area change less than 23%, and also right atrium short axis diameter indexed by body surface area equal or greater than 25 millimeters. Also, reduced left ventricular ejection fraction has been found to be the strongest independent predictor of adverse outcome. As a conclusion, arrhythmogenic cardiomyopathy cannot be diagnosed by a single test, even cardiac MRI, and it's a clinical diagnosis supported by several criteria. Clinical information prior to echo exam is a key point to suspect and detect echo findings of arrhythmogenic cardiomyopathy. Optimal visual RV wall and motion analysis is crucial, and all RV regions should be visualized during the examination. Always, we have to exclude phenocopies such as congenital anomalies, pulmonary hypertension, cardiac sarcoidosis, and myocarditis. Deformation imaging has an important role in early detection of subtle wall motion abnormalities and prognostic assessment. Always, we have to consider arrhythmogenic left ventricular cardiomyopathy as a differential diagnosis of low QRS voltages, and echo is the method of choice for follow-up of arrhythmogenic.
Thank you, Dr. Samadov, for your and all the speakers in this section. Dr. Tuo, there is a question to you from Dr. Henner. What are the lesions that we can accurately diagnose in the first trimester by fetal echocardiography?
As I said before, usually the best age for performing the fetal echo is the second trimester, so between the 18th and the 22nd weeks of gestation. But there are some conditions, for example, when the family had already a baby with a congenital heart disease, in which we can anticipate the exam. So actually we can perform the echo also earlier in 14, 15 weeks of gestation, and we can diagnose the major congenital heart disease, especially the ones in which the one ventricle is missing, and also the one in which there is the transposition of the great artery or a malposition of the great artery. But it is sure that then we have to repeat the echo also later, because some structures like the pulmonary veins are very difficult to assess when we perform the echo so early. So we have to repeat it. But yes, I think we can diagnose all the major congenital heart disease also in the first trimester.
Okay, thank you very much, Dr. Abdallah. Do you need to say anything, add anything, or other participants?
Yeah, I would like to ask Professor Giovanni Di Salvo about the applicability of artificial intelligence nowadays. What are the obstacles for their applicability? The cost of these softwares, or if they are still tested for reproducibility or whatever.
Thank you very much for this question. I think nowadays we are already in the era of artificial intelligence. And as we know, there are many softwares available on our machines where we can do automatic measurements, and these reduce a lot our workflow and time for each echo, and of course improves a lot dramatically the reproducibility. But not only that, we can also, using big data and incorporating images from normal, healthy hearts and also congenital heart disease, we can use artificial intelligence to better identify the structures. Also, the image quality that we have nowadays on our top level echo machine are corrected, purified, let's say, with some artificial intelligence. So I think artificial intelligence is already here and is here to stay. The cost, yes, depends on what we want to do. For some application, is still high, let's say, but I think, to be honest, that in the near future, this will be implemented in the clinical practice even more than it is already now, and we didn't realize it yet. Huh?
Thank you so much. Thank you.
Thank you.
Dr. Nihan?
I think that's all. Thank you very much for your contributions to all. See you later. See you next year, face to face, I hope.
Yes.
Have a nice day.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Bye-bye. Bye-bye, everybody.